report on the department's current efforts on rural health. I look forward to hearing your testimony on both panels, and now I would recognize Mr. Stearns for an opening statement.
Thank you, Mr. Chairman. I ask unanimous consent that my colleague, Mr. Henry Brown, who is the subcommittee ranking, his opening statement be made part of the record.
Without objection, so ordered.
Okay, I am here in his behalf. So I am pleased here this morning for our Health Subcommittee hearing on ensuring that our veterans living in rural areas are receiving the quality health care they certainly deserve. Today's hearing affords us the chance to examine how the Department of Veterans Affairs is how they're spending some of the funds allocated to them in the FY 2009 Appropriation Act. Specifically, we are focusing on funds that were marked to help further the VA's rural health initiative in areas such as mobile health clinics and telemedicine. My colleagues, we're all aware of the health care gaps that exist for veterans that reside in the rural areas. We know that almost 40% of veterans enrolled in VA health care live in rural or highly rural areas, and that 44% of our veterans returning from Iraq and Afghanistan also reside in these rural areas. Veterans living in the rural America are statistically shown to have lower quality of life scores and are more likely to suffer from treatable diseases. Clearly, this is an issue we must address and monitor very closely. So I applaud the VA's current outreach efforts to recruit and retain more healthcare providers to serve in rural areas and to pursue innovative healthcare methods such as telemedicine. We're moving in the right direction, but we must stay the course, and the VA must fulfill the goals it has set. I welcome our panel of witnesses and look forward to hearing more about how the VA has and intends to further distribute the funds allocated to them under the FY9 Appropriations Act so that we can truly begin closing the health care gap for our nation's rural veterans. Also, on behalf of Mr. Brown, my colleague, I'd like to extend a special welcome to one of our witnesses on the first panel, Dr. Graham Adams. He serves as the Chief Executive Officer and provides overall supervision and direction for the South Carolina Office of Rural Health. Thank you, Mr. Chairman.
Thank you very much, Mr. Stearns. And I will apologize up front. I do have to leave for another meeting shortly, so I do want to apologize up front. But we'll start the first panel. The first panel, we have Joy Elam, who represents the Disabled American Veterans, as well as Dr. Graham Adams, who's the Chief Executive Officer of South Carolina Office of Rural Health. So once again, I want to thank both of you for coming here this morning. Look forward to hearing your testimony and as well as working with you as we move forward to do what we have to make sure that our veterans in rural areas get the adequate health care in the timely fashion that they need. So without any further ado, Ms. Elam.
Mr. Chairman and members of the subcommittee, thank you for inviting DAV to testify today. We value the opportunity to discuss our views on funding and coordination of care for rural veterans. We recognize that rural health is a difficult national health care issue, not isolated to VA. We also appreciate that many sick and disabled veterans in rural areas face multiple challenges in accessing VA health care services, even private services under VA contract or fee basis. We deeply appreciate the due diligence of this subcommittee and Congress by enacting legislation which authorized VA to establish the Office of Rural Health and the resources it has provided to carry out its mission. It appears VA is reaching across the department to lay the foundation for improving the delivery and coordination of healthcare services to rural veterans, and DAV is pleased and congratulates VA on its progress to date. VA's appointment of rural care consultants in all its divisions, establishment of 3 rural health resource centers, and a number of new rural outreach clinics harnessing telehealth and other technologies to reduce barriers to care are all positive steps forward. In VA's 2009 Appropriations Act, Congress approved $250 million to support new and existing rural health care initiatives and $200 million to increase fee-basis services. It appears that VA has distributed $22 million to its VISNs for rural health care improvements, with an additional $24 million being used to establish the pilot programs, new outpatient clinics, provide outreach to rural veterans returning from the wars in Iraq and Afghanistan, and activate a number of mobile health clinics, including a fleet of 50 mobile vet centers. We appreciate the subcommittee's interest in conducting this oversight hearing, and we're interested in learning more from VA about the specific instructions issued to the field guiding the use of these new funds for rural care, what monitoring is being conducted related to the use of those funds, and the degree and type of reporting requirements that have been imposed related to the number of veterans served, as well as the information on access, quality of care, and workforce issues. Although VA is off to a good start, we believe it faces a number of challenges. In our testimony, we've offered a series of recommendations we hope the subcommittee will consider as it continues its work in this important area. Initially, we suggest VA be required to provide more thorough reporting to this subcommittee to enable meaningful oversight of the use of the funds provided and to properly evaluate the implementation phase of rural health initiatives. Without this type of oversight, we are concerned that the funds Congress provides may simply be melded into VA's equitable resource allocation system without the means of measuring whether these new funds will be obligated in furtherance of Congress's intent, specifically to enhance healthcare services and health outcomes for rural and highly rural veterans, and particularly our newest generation of war veterans. Reports to Congress should include standardized and meaningful measures of how VA rural healthcare capacity has changed, with workload changes reported on a quarterly or semi-annual basis, and disclosure of other trends that reveal whether the rural health initiatives and funds allocated for them are truly achieving their purposes. Health workforce shortages and recruitment and retention of healthcare personnel are also a significant challenge to rural veterans' access to VA care and the quality of that care. The Institute of Medicine recommended that the federal government initiate a comprehensive effort to enhance the supply of healthcare professionals working in rural areas. We believe VA's Office of Academic Affiliations, in conjunction with ORH, should develop a specific initiative aimed at taking advantage of VA's affiliations to meet clinical staffing needs in rural locations. Finally, DAV is concerned about the organizational placement of the Office of Rural Health within VHA's Office of Policy and Planning and recommends it be placed closer to the operational arm of VA management. We also suggest increasing staffing levels for the office and urge Congress to continue to provide appropriate financial support to ensure VA sustains these new activities without diminishing resources for VA specialized medical programs in accordance with DAV Resolution 177. In summary, DAV believes VA is working in good faith to improve access and medical services to veterans living in rural areas, and we are hopeful that with continued oversight from this subcommittee, supported by appropriate resources, rural veterans will be better served by VA in the near future. That concludes my statement, and I'm happy to answer any questions you or members may have. Thank you.
Thank you very much for your testimony. Dr. Adams?
Thank you, and I appreciate the opportunity to speak this morning. I'm Graham Adams, CEO of the South Carolina Office of Rural Health, past president of the National Organization of State Offices of Rural Health, and a trustee on the board of the National Rural Health Association, the NRHA. The NRHA is a national nonprofit organization whose mission is to improve the health of the 62 million Americans who call rural home. The NRHA has long focused efforts on improving the physical and mental health of our rural veterans, and I appreciate this opportunity to testify once again. Since our nation's founding, rural Americans have always responded when our nation has gone to war. Simply put, rural Americans serve at rates higher than their proportion of the population. 19% of the nation lives in rural areas, yet 44% of U.S. military recruits are from rural America. And sadly, according to a 2006 study, the death rate for rural soldiers is 60% higher than the death rate for soldiers from cities and suburbs. Mr. Chairman, because of this great level of service, it is incumbent upon each of us to do more for our rural veterans. There is a national misconception that all veterans have easy access to comprehensive care. Unfortunately, this is simply not true. Access to rural veterans can be extremely difficult, and access for rural veterans in need of specialized mental or physical care can be daunting. In brief, because there is a disproportionate number of rural Americans serving in the military, there is also a disproportionate need for veterans care in rural areas. Program expansion and resource coordination are critical to improve the care of rural veterans. We must be mindful of long-term costs and needs because the wounded veterans who return today won't need care for just the next few fiscal years. They will need care for the next half-century. The National Rural Health Association supports the 5 following recommendations. 1, access must be increased by building on current successes. Community-based outreach centers, or CBOCs, and vet outreach centers open the door for many veterans to obtain primary care within their home community. The NRHA applauds the success of these programs, but there are simply too few of these centers. In my state of South Carolina, there are only 11 CBOCs and 3 vet outreach centers, despite the fact that South Carolina is one of the top 20 states in which veterans reside. 2, access must be increased by collaborating with non-VHA facilities. Because rural VA facilities are too few and far between, many rural veterans simply forego care. If critical preventative care or follow-up treatment is not received, a veteran will undoubtedly become sicker and in need of more costly care. This must change. The NRHA's goal is not to mandate care to our rural veterans, but to provide them a choice, a local choice. The NRHA strongly supports the Rural Veterans Access to Care Act, which was signed into law last October. The act establishes a 3-year pilot program which will allow some of the most underserved rural veterans the choice to access their care from a local provider. Despite the limitations of this program, it's a strong and important step in the right direction, but more must be done. Linking the quality of VA services with rural civilian services can vastly improve access to health care for rural veterans. As long as quality standards of care and evidence-based treatment for rural veterans is adhered to, the NRHA strongly supports collaboration with community health centers, critical access hospitals, and other small rural hospitals and rural health clinics. 3, access must be increased to mental health and brain injury care. Currently, it appears that traumatic brain injury, or TBI, will most likely become the signature wound of the Afghanistan and Iraqi wars. Such wounds require highly specialized care. The current VHA TBI Case Managers Network is vital, but access to it is extremely limited for rural veterans. Expansion is needed. Additionally, 85% of mental health shortages are in rural America. Vet centers do offer mental health services, but the services are not consistently available at a local rural level. 4, care for rural veterans must be better targeted. Returning veterans adjusting to disabilities and the stresses of combat need the security and support of their families in making their transitions back into civilian life. The vet centers do a tremendous job in assisting veterans, but their resources are limited. Additionally, because more women serve in active duty than in any other time in our nation's history, better targeted care is needed for rural women veterans. And 5, improvements must continue with the VA Office of Rural Health. The National Rural Health Association calls on Congress and the VA to fully implement the functions of the VA Office of Rural Health. Efforts to increase service points have not always been embraced by the VA. It is our hope that the Office of Rural Health and the newly formed VA Rural Health Advisory Committee will work to eradicate previous barriers and expand access options for the betterment of our rural veterans. The NRHA also strongly encourages greater coordination between the rural health coordinators housed in each VISN and state-level officials in each state Office of Rural Health. Mr. Chairman, thank you again for this opportunity. The NRHA's full recommendations can be found in my written testimony. I look forward to working with you and this committee to improve the rural health care access for millions of veterans who live in rural America, and I ask that my full statement be submitted into the record. Thank you.
Yes, thank you, and if there's no question, that will be entered into the record. I would like to ask, first, thank you for sharing your concerns about the organizational placement of the Office of Rural Health, but you recommend that the office be moved from the VA's Office of Policy and Planning to an operational arm of the VA system. And by moving the Office of Rural Health to an operational arm, please explain how you think we would improve the planning and coordination capabilities of the Office of Rural Health.
Thank you for the question. I think that we're concerned that there's a number of bureaucratic levels that the office is required to go through to the implementation phase under probably Mr. Feely's office. direct access to that office with, talking to the VISN directors and the local medical center directors directly is going to be, I think, critical during the implementation phase of this program. I think they need to coordinate with Office of Policy and Planning and continue. I mean, there's a number of initiatives that they're starting which, cross throughout the departments, but at the same time, we'd like to see the office have that direct access to make sure that these things get implemented in a very expeditious manner.
Okay. Also, as you know, the VA received $250 million in the 2009 appropriation. What are your views of the type of services and programs that the VA should support with this funding, and do you agree with how the VA has spent it so far?
Just in reviewing very briefly this morning the VA's testimony, I haven't had a chance to look at it thoroughly, but it appears that they have a number of programs that have been initiated, many of them just at the very beginning stages, trying to establish many of these clinics, probably working with their coordinators in each of the VISNs and a variety of other functions. So I think that they're going to, that they have a tall task, ahead of them in terms of their, the things that they have, scheduled to do. So I think that they need to just continue to, to keep working on the programs that they've set forth as indicated in their testimony, and I think many of those are the right direction. It's just a tall order, and it seems like a lot of things are just at the very, beginning stages.
Dr. Adams, in your testimony, you highlighted the need for rural providers to be trained and because of the unique needs of rural minority and female veterans. And being from New Mexico, where it's a large rural district, we have a lot of the same needs that you were discussing. And I was just wondering if you might be able to expand a little bit on this and tell us a little more about the needs.
Yes, sir. So often in a physician or a provider's medical training, they receive excellent clinical training, but they don't have the other cultural competency trainings that are so key when you work with disadvantaged populations, be it women, minorities, others. And I think, especially when working with these populations, you do need to have special sensitivity to those issues. I also think that in states and regions that have a high minority population, where possible, the providers serving those populations need to be reflective. So trying to achieve greater diversity in ethnicity and race among those providers that are providing care would be a good thing and could be accomplished through contracting or cooperative arrangements with other non-VHA facilities such as community health centers, rural health clinics, and critical access hospitals.
I'd just like to say that coming from the 2nd District of New Mexico, which is bigger than the state of Pennsylvania, and having almost 200,000 veterans in our district, I'm really encouraged to hear the input that you're having and how you're addressing similar concerns across the country from both of you. And I guess at this time, I would, Mr. Rodriguez from Texas, would you like to have?
Yeah, thank you very much. First of all, thank you, Mr. Chairman. And let me also just indicate that my district is one of the largest in the nation. I have 785 miles through the Mexican border. I have 2 major cities, but within my district, I don't have any clinics or anything. We've had a serious problem of the VA with the ones that they have contracted out in the past are not willing to work with them now because of the fact that they had not gotten paid the way they should. And now they've gotten some new contracts, but one of them and this is probably not to this panel, but to the other, is that there's some other contractor in between that I guess is getting 15% from the top before the other person even gets paid, which doesn't make any sense whatsoever. And and I still haven't seen any results in my district in terms of the efforts of some of the pilot programs and trying to get some mobile units out there, and that hasn't happened. And so I have a large number of veterans in my district. It has extremely rural areas where people have to go. A straight shot on I-10 is 550 miles between one side and the other. And so and the major facilities are in San Antonio and El Paso, but my district is in between, a large number of it. And so I have problems with the contracting that has gone with some of the local providers that have basically, in one case, they actually stopped providing services because the VA was not timely in reimbursing them. And they just said, look, I've had enough. I'm not going to deal with this. And the other, we had two groups, actually, two community-based outpatient clinics that they used to work with that are unwilling to work with them now because of past experiences with them. And so I just wanted to see if you might comment as to how do we get past some of the things that have happened in the past, and how do we make sure that they deliver in the future?
I believe that creating incentives, financial and other, for VA facilities, be it CBOCs and vet outreach centers, to coordinate and to work with non-VHA facilities will go a long way to creating those partnerships. In some cases, veterans are being seen in these facilities already, and the non-VHA facilities that I mentioned, rural health clinics, community health centers, and critical access hospitals, these are all fully qualified, fully staffed facilities that are providing care at the local community, all of which receive some kind of enhanced arrangement from Medicare to provide services, but unfortunately not for veterans. So if that linkage could be put in place, I think that you'll see increase to care increase dramatically, and there'll certainly be things that have to be worked out, but you have folks that are in the field right now that are willing to see veterans if only a mechanism existed to do so.
This might help. That mechanism that you're referring to, that require any form of additional legislation, or is that something that is already in place that we could just require them to do?
I can't speak exactly as to what authority the VA has, but if the authority would allow, and if the intent were there are partners on the provider side that are more than willing to see these veterans as long as they're reimbursed fairly and they're in these communities. There's no sense in reinventing the wheel, building another facility, investing additional taxpayer dollars when you have points of access already there.
Thank you very much. Thank you, Mr. Chairman.
Next, I need to apologize to the gentleman from Kansas. I'm sorry, this was my first time to chair this committee, and I guess it's showing in the going out of order here, but I would like to at this time represent Congressman Moran from Kansas.
Because you're new to the committee, you don't know how offended I am, how difficult I am to get along with. Mr. Chairman, I'm delighted to be here, and I'm happy to be able to visit with these witnesses at your leisure, at your convenience. I thank Mr. Michaud and this subcommittee for having this hearing. The pilot program is a piece of legislation that I have worked on really since I came to Congress, and I'm delighted that Mr. Michaud has indicated a willingness to have a hearing. My staff met with folks from the VA and others yesterday for the beginning implementation conversation, and we're generally pleased that the VA is paying a lot of attention to this topic, and I think it's important for all of us to stay on point to make sure that it's implemented in a way that demonstrates the value of this pilot program. Dr. Adams, in your in the testimony of the Disabled American Veterans, and Ms. Ilham's testimony, she indicated concerns about veterans who may seek health care for convenience with a private provider, that they may not receive the protections of the VA system, patient safety and other protections that indicated are in in the VA system. Do you have any concerns about how a veteran would be treated in the private system with their hometown doctor and hospital as compared to being more directly in the VA system with a VA provider? And if you do have those concerns, do you have suggestions of what it is that we ought to be paying attention to make sure those concerns are addressed? Dr. Adams?
Thank you. I don't have concerns. Certainly there are the VA with the system that they have, they provide excellent care in those facilities. The problem is there just aren't enough of those facilities. So if we can create linkages where there is reasonable requirements for electronic medical records, for quality of care, then there's no reason that that those veterans can't receive high-quality care in non-VA facilities. All these facilities meet every quality requirement of the federal government that is put upon them. So these are highly trained folks doing the work that they need to do, and they don't currently have to abide by all the VA rules, but as long as there were reasonable, and I stress reasonable, requirements in place, I don't know why those partnerships couldn't exist.
In my early days in Congress, our outpatient clinic was staffed by a physician in her private practice, and she ultimately left the system and no longer provided services to veterans through her clinic as an outpatient clinic of the VA. And the concern, the criticism, the difficulty was related to medical records, to technology, and the inability to connect and getting answers from the VA, and in our case in Wichita. Much of that has been resolved. Do you have a sense that, at least my sense is that much of that's been resolved? Am I missing something? Or are we headed the VA seems to me to be probably one of the better utilizers of technology in the entire medical delivery system.
I think that's correct. The VA has a excellent electronic medical record system. All the dollars that are contained within the AARA are going to allow even more facilities in rural communities, non-VHA facilities that don't have EMR now, that don't have electronic medical records now, to have that in place. So I think that the ability for information to be exchanged in a HIPAA-compliant, safe way is going to be less and less of an issue once all of these facilities have some form of electronic medical records.
Has anyone in the VA's Office of Rural Health ever contacted you, or do they reach out to people in your position to seek advice and suggestions?
I do have to say the Office of Rural Health has been very supportive and very helpful with entities like the National Rural Health Association. I think from a staff perspective, they've done a great job of creating goodwill and seeing where those partnerships could exist. I get the sense it might be a little bit higher up the food chain, if you will, within the VA, that some of this resistance occurs. And from my perspective, at a state level, each of the VISNs has I believe it's called a rural health coordinator. I don't know who that person is. I've never been contacted by that person. I've tried to go on the VA website and identify that person. I can't do that. So I would strongly urge for those rural health coordinators, if that's the correct term, that are located within each VISN to be more proactive, reaching out to the state-level rural health officials in each state.
I'll try to ask Ms. Hawthorne the similar kind of question when she's our witness. There is a Rural Veterans Advisory Commission now, and I want to hear about how it's interacting with the VA and what difference it's making. My time has expired. I thank the chairman for his indulgence and appreciate your consideration.
Well, once again, I'd like to apologize to Congressman Moran, and I appreciate his patience with me in my learning process here. And next is the congressman from California, Jerry McNerney. Do you have a question, please, sir?
Thank you, Mr. Chairman. First of all, I'd like to thank the witnesses for coming forth today. Mrs. Illiam, is that correct? Ms. Illiam, you suggested more oversight by the committee, and I think that's probably a good idea. But I was wondering if you had, and you also mentioned standardized reporting. Do you have specific recommendations or specific ideas for standardizing the interchange between the committee and the witnesses or the reporting entities?
I think, VA would be able to do that fairly easily. I think, the request from the committee to do that, I'm sure they would be willing to provide that. And I think the main thing would to be not just a data dump, but something that you could really read and be able to, make a true assessment. Is capacity improving? What are the workloads? What are they doing? In briefly looking at their testimony, I think they have a number of reporting requirements that they're requiring from the field. And if they can tally up that information in a very sensible way that would be easy for the committee to review, I think would just be another opportunity to really have the oversight that's needed.
Okay, well, thank you. Any ongoing suggestions you have on standardizing that would be appreciated by the committee.
Sure.
And you also mentioned more physicians is one of the major problems. Do you see that as the major problem, or are there other related problems to the shortage of physicians in rural areas?
I think that's, one of the issues. I mean, there's so many factors involved in rural health care issues that, the nation is grappling with in general, including VA. I think that's just, obviously one of the key issues, to have the willingness for qualified people to be in the area and available to these veterans. But I think it's one of many things that are necessary.
Thank you. Dr. Adams? I want to say I have both rural and suburban areas in my district, and I appreciate your mentioning the disproportionate share of active duty members and veterans from rural areas. I was just at a funeral in a town of mine, about a 60,000 people town, and it's their 8th fatality in the war on terror. So they certainly are paying their share, or more than their share. And I also appreciate your suggestion to let non-VA organizations partner up with VA organizations to provide the best possible care to our service members. I'd like to see, speaking of standardized, I'd like to see a standardized approach to that so that we can move forward aggressively and provide those services in a way that would benefit everyone. One of the questions I have is, do you see the telenet being helpful in filling the gap between rural and urban service capabilities?
I think telemedicine, telehealth is a great tool to provide some services in more isolated rural communities, specifically things like telepsychiatry. It can be fairly effective with. I think that while telemedicine and things like a mobile clinic are great steps in the right direction, they don't nearly provide the continuity of care that a full-time provider or a facility would in those rural communities. And again, we have a very robust network throughout the country of folks that are already in place to serve the underserved and to serve vulnerable populations. And I think we all could agree rural veterans are a vulnerable population. So providing linkages with those folks, I think, again, will increase access to care dramatically. Telemedicine is a wonderful thing, and I think it can be used in conjunction with some additional agreements in place at the local level.
Thank you. Ms. Ilm, do you have any comments on telemedicine?
No, I mean, we think that's another great opportunity to be able to be used in the arsenal of, looking at all of these issues that can help to improve services in those communities.
Thank you. I'm going to yield back, Mr. Chairman.
Thank you, Congressman McNerney. I appreciate those comments. At this time, I'd like to call on the lady from Illinois, Congresswoman Deborah Halverson.
Thank you, Mr. Chairman. And I would like to start with Dr. Adams. In your testimony, you highlighted the need for rural providers to be trained to meet the unique needs of the rural minority and female veterans. Everywhere in every panel that comes before us, they talk about the need for women veterans and the fact that more and more are coming back, and there's going to be a huge need. this is going to really complicate a complicated issue even more. What do you suggest we do when there's already a need for more rural services, and now we're going to need more help with the women population coming back?
I think that can largely be addressed through increased mental health and behavioral health services. Every veteran that comes back has issues potentially with combat situated problems, and the females who come back often have family burdens, they have children, they have different roles than a male typically plays in our society, and they have different expectations when they come home. So I think a lot around family counseling, marital and other family counseling being available for the family as a whole, not just for the veteran, is key. So often when it was just a male veteran population, they didn't have some of those expectations when they returned home. I think you're finding that more and more with returning female veterans.
So, and if I could ask both of you to comment on this one. So you feel that we should be treating the entire family, because I know that there's been some discussion, which has completely caught me off guard, about women who have children while a veteran, and how these children are not veterans, but yet we have to find a way to take care of them, and there's been a lot of discussion about that. What are your views on, these are veterans, they've served our country, and now we're debating whether to even take care of their children?
I would just start out, thank you for the question on, women veterans and bringing it up, and I think it's great that Dr. Adams included that in his statement. This is an issue that VA is working very hard to address right now through their Office of Women's Health Program and the Center for Women Veterans. But they do indicate, an increasing number of women veterans obviously returning, and high rates of use among this OEF population coming to VA with a changing demographic. I think that it'll be really important in the next year for the Office of Rural Health to also reach out to Dr. Patty Hayes' office at VA to really make sure that within the rural health question and initiative that these issues are addressed with respect to women veterans. I think that's great. And, some of the programs that VA has specifically for women veterans are really important in terms of post-deployment issues and some of the things that Dr. Adams has referred to in their post-deployment readjustment. So we want to be able to, in the rural health communities, for those veterans to have that access to VA's unique specialties in providing those types of service, or training local people that are seeing them to be able to do that. And with respect to the child care issues, this has been a longstanding issue in the women's community, that this is a barrier, but we see it not only as a barrier for now just women. There's so many single veterans in general, other than just both men and women, that have child care issues, primary care responsibilities. And I think you're referring to the pilot program recommended by Congresswoman Stephanie Herseth-Sandlin.
Mm-hmm.
And we think that having, when we look at all the research that's put out there, that's one of the big barriers. So certainly, if there's an opportunity to provide, not VA directly providing child care, but providing some sort of CHIT for them to access health care while they access child care so that they can attend their appointments, especially if they have post-deployment issues that require extensive mental health sessions. Really wouldn't be appropriate for them to bring their children. So we just hope that that's a consideration, that the subcommittee will take up as it looks at that bill further.
Did you have anything to add, Dr. Adams?
Beyond child care, I do think that the counseling resources should be available to the families as well, because so often if the veteran returns home with either psychosocial or severe physical issues, the family are the caretakers, and they're the ones that are bearing the burden 90%, 99% of the time. So I think resources should be available to them, because so often in our rural communities, mental health and behavioral health services are just not available. They aren't available for the general population, and at least in my state, our local community mental health centers won't see veterans. They won't see them because they feel that, first of all, they're overburdened, but second, they feel like they should be seen at the VA facilities. So again, creating a linkage and incentives for that to occur, I think, is vital in providing veterans and their families the services that they need locally.
Thank you.
Yes, the Congresswoman from Illinois, thank you for those questions because they needed to be asked, and thank them for addressing them. And now at this time, I'd like to recognize the gentleman from Indiana, Congressman Donnelly.
Thank you, Mr. Chairman. In regards to TBI, Dr. Adams, you had mentioned that earlier, and this is for both you and Ms. Elam. There are approximately 4 centers throughout the country, polytrauma centers, to help with this through the VA system. And if you get in a very rural area, it's hard to get treatment for this. Would you fully support the opportunity for our vets to receive treatment at either one of our centers in the VA system, or to go to a place like the Chicago Rehabilitation Institute, where they can go and receive very intensive additional care for this injury? And there are similar facilities throughout the country. I was thinking I wanted to find out what you think of expanding the range of places where our vets can go.
I absolutely think that creating additional access points makes sense. And yes, we all want the quality of the VA system to be held intact, and we want to make sure that the veterans' health information is kept private. But all these things can occur in private settings, and it's of little solace to those that need the care who can't get it, knowing that there's 4 centers that do this and do it excellent if they can't get there. Accessing additional facilities, as you mentioned, that have the expertise, to me makes great sense, and it's really just a matter of choice and access, making sure that these veterans get care no matter where it is, as long as it's of high quality and it meets reasonable standards.
I would just mention, obviously for the most critical cases that are very, just coming back, the major polytrauma centers are where they're going, but VA has established also in each of their visits a level 2. So it would depend, certainly on the level of the injury and the needs of that veteran. And I know that they have options to outsource that care if necessary and working with a family. Of course, we want veterans to have the best care, and for those that are really working with these very unique injuries and the polytraumatic injuries they're seeing from the wars in Iraq and Afghanistan. So I don't think we're opposed to, in certain circumstances, making that available. Certainly the family, there's a lot of family issues. We want the families to be available and to be with them, and we know that many have had to relocate, giving up jobs and a variety of other things that have made it very difficult, or leave one parent at home and not be able to stay in their local area. So I think those things should be taken under consideration for VA with the unique circumstance of the family.
Okay, and again, this would be for both of you. In terms of listing, here's the problem with outsourcing some care for veterans when you have local doctors or local facilities. What do you find the biggest barriers? Cost, the technology in the health clinic? What are the kind of things that make it most difficult for rural vets to be able to receive assistance locally, as opposed to having to get in a van and travel 3 hours to the VA clinic? And the VA clinics are extraordinary places, but if you can save yourself a 3-hour trip, it would be a lot better off. What are the kind of things preventing it from happening?
From my perspective, the largest barrier is that, except for in a few isolated pilots, the VA won't pay for care at these local facilities. So
won't pay at all, or at an appropriate level?
To my knowledge,
What would you consider an appropriate level?
Well, to my knowledge, unless a veteran resides in one of these areas where they have a rural pilot, a veteran cannot go to, say, a community health center or just a private doctor, be seen, and have that care reimbursed by the VA.
So it's not that the doctor or the clinic itself won't meet a pay number set by the VA. The VA just won't participate.
My understanding, I mean, VA has the option through its fee basis program to, if there are geographic barriers in a number of certain circumstances, they can authorize fee basis care, you know, based on the individual circumstances of the veteran and location and a variety of other factors. But they do that on an individual basis. So VA does currently have that authority. The problem we've heard is that through the Vera distribution of the dollars for those programs, you know, they oftentimes are only allotted a certain amount of money for those fee basis programs. So they're very judicious, you know, in how they, you know, they allow veterans, and if there's an opportunity to get them to the nearest clinic, even though it may be several hours away, you know, that may be, you know, that's where they want them to go. But I think looking, as part of the establishment of the Office of Rural Health, there was a request to look at the fee basis program, and I know there's been some increased funds in the 2009 appropriation for increasing fee basis. And I would assume that VA, you know, that the Office of Rural Health is really looking at the fee basis issue, and to use it, you know, appropriately when necessary, and not, you know, especially when you have some very elderly veterans or somebody with TBI that's, you know, it'd be very difficult for them to make extensive trips to and from a facility for a number of trips if, you know, required by their medical condition.
Okay. Thank you very much. Thank you, Mr. Chairman.
Thank you, Congressman from Indiana. I appreciate that. And also, Joy Elam and Dr. Adams, thank you for your participation. I think that the information and knowledge that we received from you today will be helpful as we make the decisions that we have to make down the road. And I really do want to thank you for participating, and thank you.
Thank you.
Thank you.
Now, at this time, I would like to call panel number 2 to come to the table. Have Dr. Adam Darkins, who's the Chief Consultant, Office of Care Coordination, Veterans Health Administration, U.S. Department of Veterans Affairs, and Kara Hawthorne, Director of the Office of Rural Health Care, Veterans Health Administration, U.S. Department of Veterans Affairs. Once again, thank you for being here today and taking a part in this. And Dr. Darkins, we'll start with you, please.
Good morning, Mr. Chairman. Thank you for the opportunity to testify before the committee today. My testimony covers funding and resource coordination issues associated with the expansion of telehealth programs within Department of Veterans Affairs, or VA, and how they help meet the health needs of veterans in rural areas. Health care delivery in rural areas is a challenge, as we've just heard, one that the VA is confronting directly. Telehealth involves the use of information telecommunications technology to increase access to care and reduce travel. In fiscal year 2008, VA's telehealth programs provided care to over 100,000 veterans in rural areas. These telehealth-based services involve real-time video conferencing, store and forwards telehealth, and home telehealth. Real-time video conferencing services in VA, known as Care Coordination General Telehealth, provide specialist services to veterans in both VA medical centers and in community-based outpatient clinics. The main focus of this program is in providing mental health services in rural areas, and in 2008 provided services to 20,000 veterans at over 171 sites of care. And of these services, they included 2,000 returnees from Operations Enduring Freedom and Operation Iraqi Freedom. Store and forwards telehealth, care coordination store and forwards, known as in VA, involves the acquisition, interpretation, and management of patients for screening and assessment purposes using digital images. These services were provided to over 62,000 veterans in rural areas in 2008, and were predominantly provided to provide care for diabetic eye disease screening and for skin diseases. To enable veterans with chronic diseases to live independently in their own homes and local communities, VA provides home telehealth services. In financial year 2008, these services, known as care coordination, home telehealth services in VA, supported 35,000 veteran patients to remain living independently in their own homes. 40% of these patients were in rural areas. VA is very sensitive to the increasing need for services in the home, particularly in rural areas, and is preparing for the future demand by expanding the range of these services it provides, as well as other telehealth services. And I'm going to describe briefly some ways in which this is happening in the next year. Firstly, we're formalizing and implementing a national program using telehealth to help support the 41,096 veterans with amputations who receive care from VA. Secondly, we're instituting a program to expand the use of telehealth in both home telehealth and in general telehealth to support spinal cord injury and disorder services, and to make this renowned specialist care more available, especially into rural areas. Thirdly, we're completing the necessary work to implement VA's Managing Overweight and/or Obesity for Veterans Everywhere program, known as MOVE, and this is going to be incorporated with home telehealth, and it will help to expand into rural areas. Fourthly, we're completing a program for supporting veterans with substance abuse issues using home telehealth technologies. And the last one I'd like to focus on is establishing a national telemental health center which will coordinate telemental health services nationally. Its particular emphasis will be on bipolar disorders and on post-traumatic stress disorder, and on making those services widely available. In implementing telehealth solutions to serve veteran patients in rural areas in the ways I've described, collaborations with colleagues within and outside VA is vitally important. We collaborate with mental health, medical surgical services, rehabilitation, prosthetics, spinal cord injury and spinal disorders, amongst many other offices, who provide invaluable expertise that ensures VA's telehealth services are appropriate, safe, effective and cost-effective. Telehealth is a marriage between clinical care and technology, and another key ongoing collaboration is that we have with information technology colleagues in order to underpin a robust and sustainable infrastructure to deliver care nationwide. In financial year 2009, VA is piloting an extension of its pre-existing polytrauma telehealth network to create a clinical enterprise video conferencing network. This will facilitate the extension of polytrauma, post-amputation, spinal cord injury care, and specialist mental health services to rural areas. These efforts, combined with VA's personal health record, My Healthy Vet, leverages new technologies to benefit our patients. VA's Office of Rural Health provides a focus we welcome to address the needs of veteran patients in rural areas and dovetails services into the spectrum of healthcare provision necessary to support these veterans. VA has a long-standing relationship with the Joint Working Group on Telehealth, an interagency group. Cross-fertilization of telehealth practices with other federal partners assists us in developing services, for example, those we deliver to meet the needs of populations, such as those in American Indian, Alaska Native, and Pacific Islander communities. VA has 3 telehealth training centers. It's trained over 6,000 staff to ensure a workforce that's competent using those modalities wherever possible that are virtual. The safety and efficacy of VA's telehealth programs is substantiated by a national quality management program that reduces utilization and shows high levels of patient satisfaction with the telehealth programs. Key to the development of telehealth in VA is the energy, expertise, and dedication from various staff from different backgrounds. They're united in their commitment to serve veteran patients. It is a privilege to work with such colleagues throughout VA and engage in implementing groundbreaking services, those who've served our nation and for whom we're committed to serving, whether they live in rural, highly rural, or urban locations. This remains VA's mission and one we gladly accept. Mr. Chairman, that concludes my prepared statement. I'm pleased to address any questions the committee may have for me.
Okay, thank you. Next, Kara Hawthorne, please.
Thank you. Good morning, committee members. Thank you for the opportunity to discuss VA's work to enhance the delivery of health care to veterans in rural and highly rural areas. I would like to request that my written statement be submitted for the record. VA's Office of Rural Health, referred to as the ORH, is empowered to coordinate policy efforts across VHA to promote improved health care for rural veterans. VA has embraced a national strategy of outreach to ensure veterans, regardless of where they live, can access the expertise and experience of one of the best healthcare systems in the country. In partnership, Congress and VA can do even more. We appreciate Congress's support and interest in this area, and we are happy to report that portions of the $250 million included in this year's appropriation have already been distributed to the field to support new and existing projects. Specifically, the ORH has allocated $24 million to sustain fiscal year 08 programs and projects, including the Rural Health Resource Centers, mobile health care clinics, outreach clinics, the VISN Rural Consultant Program, and mental health and long-term care projects. In December 2008, VA provided almost $22 million to VISNs across the country to improve services for rural veterans. This funding is part of a 2-year program and will focus on projects in line with the ORH strategic vision to increase access and enhance quality, education and training, information technology use, workforce recruitment and retention, and to strengthen collaboration with our non-VA partners. VA distributed resources according to the proportion of rural veterans within each VISN. VISNs were provided program guidance and directed to identify programs or projects that would support the ORH vision to enhance care delivery and outreach for veterans in rural areas, and also that they are in line with guidelines provided in Public Law 110-329 to increase the number of access points, to accelerate telemedicine deployment, to explore collaborations with non-VA partners, and to fund innovative pilot projects. The Office of Rural Health instructed VISNs to include funding, validation, and reporting with a breakdown by target to facilitate distribution and tracking, as well as execution and evaluation plans. VISNs are required to report their accomplishments based on these factors to us quarterly. In February 2009, the ORH distributed guidance to the VISNs and program offices concerning allocation of the remaining funds as early as May to enhance rural health care programs. A cross-sectional group of VA program offices came together to develop a process and a method to allocate the additional funds. Together, we developed a request for proposal. VISNs and program offices were each eligible to apply for this funding, and again, we focus on the ORH's 6 key areas: access, quality, technology, workforce, education and training, and collaboration strategies. We also required proposals include an evaluation component with specific measures to explain how the proposed work will increase access, quality, and quality of care to our rural veterans. ORH, along with the other program offices in the panel and other relevant program directors across VA, will be reviewing these proposals in early April. Proposals that recommend new technologies or those that sought to extend current enterprise programs needed to justify how these alternative solutions would be interoperable and embody the essential clinical, technology, and business processes to ensure compatibility with existing programs. Affected program offices will be involved in the review of these applications to ensure that continuity and consistency within the program areas. VA's ORH, during its short existence, has produced a number of programs that are actively improving the delivery and coordination of healthcare services to rural veterans. Some examples include expanding the existing home-based primary care and the medical foster home programs into rural VA facilities, developing the Geri Scholars Program to support geriatric providers in rural areas, supporting expansion of community-based supports for veterans with severe mental illness, opening 10 new rural outreach clinics, and also establishing the mobile healthcare pilot in 24 predominantly rural counties. The VA's Office of Rural Health is reaching across the department to coordinate and support programs aimed at increasing access for veterans in rural and highly rural communities. Thank you once again for your support to appear today, and I am prepared to address any additional questions that you may have.
I do have some questions, but due to the fact that we are fixing to go vote, I will submit my questions in writing and defer to the congressman from Kansas, sir.
Mr. Chairman, thank you very much. You've more than overcome your slight earlier in the morning. Thank you both for being here. One of the things that seems so clear to me as we have finally begun the process of increasing the funding for veterans health care is that the challenge we now face within the VA system is hiring and retaining healthcare professionals. And so as we add additional resources that make healthcare perhaps more accessible and higher quality, what is the VA able to do? What do you need from Congress in regard to the employment of people who perform healthcare services? There is a shortage generally. My hospitals, my communities all struggle to hire necessary healthcare professionals, from physical therapists to psychologists, to psychiatrists to nurses. My question is, and my guess is, that this is certainly my experience is, that this is a more difficult challenge in rural communities than it is in urban or suburban settings. And is there a concerted effort at the VA to overcome the healthcare professional shortage, particularly in rural areas, but just generally?
Thank you for your question. You are correct. It is a national problem getting rural providers, and the VA is addressing this. We have begun some initiatives to help recruit providers in the rural areas. We're linking in with non-VA entities to help advertise, to entice them to come to VA. Let me tell you specifically about one exciting new initiative that we're undertaking with the Office of Academic Affiliations. We're expanding the rural residency for physicians into more rural facilities. So what we're doing is we're able to now provide supportive services so that the physicians can practice in rural areas. Because what we've learned is that providers who do their residencies in rural areas are more likely to stay and work in rural areas. So that's just one of the examples. The other one, as I mentioned in my oral testimony, is the Geri Scholars Program. Finding specialists that concentrate on geriatric services is difficult in urban and rural areas. So we're providing some extra training to the gerontologists about our rural veterans, and hoping that they will disseminate that information among their peers in the rural communities where they practice.
Is the VA capable of compensating healthcare providers in a way that we're not at a disadvantage to the private sector?
I'm not able to answer that question directly, but I can take it back and get a more thorough answer for you.
Please do. I thank you for that. And if so, is there a request to Congress that we do something about how we allocate the resources, the increased resources, in a way that actually allow the VA to hire more providers?
Could I just...
Absolutely, Doctor.
Certainly cost is one of the factors in terms of recruitment and retention of staff. Equally well, my understanding is preferentially people from different disciplines are working within VA. And certainly culturally, it's very attractive. There's the training which my colleagues just commented on, but large training of all healthcare professionals. We're also finding, certainly the area that I work in, telehealth, the ability to link some of these rural practitioners into their specialist colleagues, and the educational aspects that go with this, to be able to link practitioners directly into training, helps prevent that isolation. So the cost is certainly something. These other factors really, I think, make VA a place where people are very proud to work in terms of the services they're now delivering.
That is a very accurate description. Communities that have a physician find it very difficult, if you're the only physician, to retain that physician. You want colleagues. Doctors do not want to be on call 7 days a week, 24 hours a day. There is a collaboration and just a professional necessity of having colleagues in your presence. The comment by our earlier panelist about not being able to find out who apparently each VISN has a rural coordinator, and yet unable to find out who that person is. Do we have those rural coordinators in every VISN? Are they accessible? What are they doing? What's the status of that program?
Sure. Yes, sir. We do have a VISN rural consultant in each VISN, and this was actually something that the committee had foresight to put into the public law that established the Office of Rural Health. Some of the VISNs have full-time positions, and some of them are not full-time. But part of their responsibilities is not only to facilitate information exchange between the field and the VACO Central Office of Rural Health, but also to collaborate with the community partners. So they're seeking out potential collaborations for direct care, for education and training, and building those relationships. I will look into your specific VISN and find out who that VISN coordinator is, and make sure that they are in touch with the State Office of Rural Health, and actually urge all of our VISN rural consultants to reach out to the State Offices of Rural Health.
I might thank you for that, and point out that in a couple of instances over a long period of time, we have tried. I've been involved in efforts. This committee has been involved in efforts to encourage the VA to employ the services of certain healthcare providers, chiropractic care, physical therapy. It always seems like there's a push to get the VA to accept certain segments of the medical profession. And I just would remind you that in both those instances, physical therapy, chiropractic care, that in rural America, those professionals are very important. They fill a real need, and I would encourage your efforts on behalf of rural healthcare to recognize not to be narrow in the way that we define who can be a provider. I think there's some reluctance to pursue the opportunities that I see there with a wide array of services that are more available in rural America in certain categories of professionals than there are just than sometimes what we look for. Let me finally, and again, my time has expired. The chairman's been very kind, but let me just thank you, Ms. Hawthorne, for your meeting with my staff. Implementation of the legislation that we've been talking about is a high priority of this committee. Many members come from rural areas. It's a high priority with me. You were very gracious, and it appears to me that you're very interested in seeing that this occur in a timely and appropriate fashion. And I'm very grateful for your attitude and approach and look forward to working with you. Thank you, Mr. Chairman.
Thank you, sir, for those very pertinent questions and appropriate issues that needed to be addressed. And at this time, I would like to ask the Congressman from California, Mr. McNerney, if he has some questions.
Well, I do, Mr. Chairman. Thank you for giving me the gavel here. And I want to follow up a little bit on some of the questions by my colleague from Kansas. Certainly recognize the shortage, a critical shortage of healthcare professionals in rural areas, and it's not just for VA services, it's a general problem. So we need to look at how to entice physicians, healthcare professionals of all kinds to come into rural areas. One of the problems we're facing in California is that our prisons are severely overcrowded, resulting in poor health care for prisoners, and now they're suggesting the courts are about to mandate that we open up health care facilities in our area that will pay far more than the VA can, and that will draw physicians further away from VA use and applications to prison, and that's very controversial, I'm sure you can imagine. So it's an area that we need to look at and maybe address at this level. One of the things that struck me about your testimony, Dr. Darkins, was the sort of difference in tone about telehealth from the prior panel. They certainly acknowledged the need for the value of telenet, but your testimony was a little bit farther than that. It was not just the value, but how it could be used in several areas, vets with amputations, vets with spinal cord injuries, weight problems, post-traumatic stress, and so on. One of the things I am concerned about with telenet is the lack of a personal touch. I mean, you have a screen in front of you, and you can see the physician. How effective is that in terms of reaching a veteran with these sorts of problems, as opposed to having someone that can actually touch their hands and look them straight in the eye? You know, how much difference is there in terms of the effectiveness of the treatment if we go that way? Because it's clear to me that telehealth is a very effective tool. We're not going to be able to get all the physicians we need, no matter how hard we try. So how effective is this treatment?
Thank you very much. In terms of the VA's use of telemedicine, let me just say in telehealth, it's not a panacea to be able to deal with all services. Absolutely, it has to fit into a spectrum of care in which it's there with face-to-face services as well. So it fits into that spectrum of services. VA's experience is certainly it's a nationwide leader, if not in certain areas an international leader. There are certain benefits the VA has to take that forwards. Very large networks. These are based on really ongoing commitment of leadership towards telehealth as a way to deliver services, particularly out into rural communities. Secondly, we don't have barriers from state licensure which allow us to develop large networks. And largely, we really put these enterprise services into place. So it's very much the scale at which it's being done in VA, I think, is much higher than elsewhere, where we have really an integrated healthcare system doing this on an enterprise level. In terms of your specifics, that's been something of enormous importance as we've taken telehealth forwards, to be able to be quite clear that this is the right care for patients, it's what they want. What we find is that telehealth services are really seen across the board by patients as being really directly equivalent in many cases to delivering face-to-face. We find sometimes people prefer to have face-to-face, but if you take into consideration the travel, sometimes the inconvenience, we're finding that people say they really enjoy the telehealth services. It's not enough to be able to say anecdotally, we've got good evidence from surveys we've done. Our home telehealth patients show an 86% satisfaction score with these services. They help them live independently in their own homes. We have 37,000 patients currently who otherwise might be in nursing homes if it were not for these services.
What sort of equipment is needed for home telehealth that a person might not ordinarily have?
Well, we're very sensitive to the fact that we're dealing with an aging population and may not be the most technology savvy. So we use simple technologies which are push button. The current connectivity is largely through telephone landlines, simple to use and communicate backwards and forwards, and we're seeing a 20% reduction of utilization, so reducing hospital visits, reduced hospital admissions using these technologies. They're really helping people with chronic disease to be able to stay living independently in their own homes and communities.
Do they need like a big screen TV, or I mean, what physical equipment do you need
They're
in the house?
small, little, unobtrusive boxes. There are 3 different ways in which this is generally done. One way is to do video conferencing into the home so somebody can directly see their provider. It means they get much more of that face-to-face contact. Obviously, a physical examination can't be done.
Right.
Second is to be able to monitor people's vital signs, pulse, weight, blood pressure, temperature. It's possible thereby to be able to keep an eye on things like heart failure. Very simply, somebody who puts on weight and gets symptomatic, it's possible to intervene early, prevent hospital admission. And the third area really is to be able to use what are known as disease management dialogues, to ask the kind of questions of a patient each day that they might be asked of their provider if they came into a clinic. So we're finding this is really targeting care. We can expedite admission to people to hospital or referral to clinics based on this personal care each day, which takes place from a VA provider back in the VA Medical Center.
Thanks. If the chairman will indulge me one more question. What do we need to do here to make sure that the VA can provide these sort of home-based services, make them available? Do we need to provide equipment or service people to come in and install, or what do we need to do here?
Well, I would say in this area at the moment, VA is very much on the leading edge of being able to take this forward. These are emerging technologies which really are not they're being used elsewhere, but not as widely in the VA. Patients are very accepting, as I said, high scores of satisfaction. We're working with the vendors that provide the services to standardize, which has been very important to be able to standardize the data. There isn't an issue in terms of our use of equipment or having equipment to be able to do this. I think our main issues as we go forwards are really just those human being issues. You touched on earlier, is it as good to be able to be using telehealth technologies as face-to-face? So paradoxically, we find a lot of the work is actually on relationships, because in the end, it comes down to relationships. So I think the things I would say is, one limiting factor is being absolutely sure we have a robust information technology backbone. We're working very hard with our information technology colleagues and outside vendors to ensure that, and that's really one index of progress. And the second really is just relationships, helping veteran patients to be accepting, which they are of this, but also our provider population for whom this is a new way of delivering care as well. So those are really our main challenges, those human challenges rather than the technology.
Sure. Thank you, Mr. Chairman.
Thank you, Congressman McNerney from California, for that. Dr. Darkins and Kara Hawthorne, I want to thank you again for coming and testifying before our committee, and thank you for the input that you've had. There'll be some other questions submitted in writing, and with that, that concludes the hearing this morning. Thank you.